Welcome to the evening symposium. My name is Ajit. I'm one of the vascular surgeons at Mount Sinai, and I have Dr. David Song. So today we really want to talk about the DETOUR device and how we use that. You know, it's a relatively new device and how we've incorporated it into our practice. So I'm going to turn it over to Dr. David Song. He's an assistant professor of medicine at Mount Sinai Hospital.
All right, so good evening, everyone. I would just like to thank Dr. Rao, Dr. Krishnan for allowing me to participate in this opportunity, and obviously Endologics for putting on this evening symposium for everybody. So we're just going to talk about, like what Dr. Rao said, advancing SFA revascularization in complex disease with the new DETOUR system, which is a percutaneous bypass system. I'll be introducing percutaneous transmural arterial bypass via the DETOUR system. The DETOUR system is really game-changing. It allows us to perform a minimally invasive percutaneous bypass of long segment femoral popliteal disease with equal surgical outcomes. And this DETOUR system is really invaluable and advanced option we have now in our endovascular toolbox to provide a solution for complex femoral popliteal disease for our PAD patients. The DETOUR system really is disruptive in innovation because it allows us to perform this percutaneous bypass with long-term durability, but without the complications and the headaches of a surgical bypass, which would include we are able to perform it with minimal trauma to the body, reduction in hospital stays, and shorter rehabilitation times. The DETOUR system is comprised of two components, the endocross device and also the torus stent graft system. In general, the endocross device is a device we use to create the arteriovenous fistula at the proximal and the distal caps of the occlusion. And also the torus stent graft system is ultimately the conduit that we lay down in order to create the bypass system. This, I'm sure you guys have seen this schematic before, but it's a step-by-step process of how to actually utilize the DETOUR system to create the bypass. Just in brief summary, essentially we use the endocross device to create an AV fistula at the proximal cap of the stenosis or the occlusion. We snare the wire that we wire through the endocross device to the distal end of the stenosis or occlusion, and then we reload the endocross device and create the distal AV fistula connection. Once we wire it back into the native vessel, then we are able to advance the torus stent graft system and lay down the conduit that ultimately creates the bypass system. The DETOUR system is a great innovative device, but it's not for everybody. For one, in our practice at our center, we really want to plan out the procedure well in order to ensure procedural success and optimal benefits for the patient. So one thing we really like to do is get a pre-procedural CTA in order to really measure the common femoral artery size to make sure that it's at least greater than 7 millimeters in diameter. There is an increased risk of DVT with this procedure, so patients with a history of DVT recently, thrombophilia, or any other hematological conditions are contraindicated for the DETOUR system. We don't use this to treat, untreated flow-limiting aortic iliac occlusive disease is a contraindication. Poor tibial runoff vessels are contraindications, and hypersensitivities to any materials that are actually inside or constructed in the DETOUR systems are contraindications. The DETOUR data is based on the DETOUR tool IDE study, and we now have 3-year results. So essentially, the DETOUR IDE is to say that PTAB with the DETOUR system achieves surgical bypass results with a minimally invasive approach, and we have 3-year results. The DETOUR IDE study is enrolled about 200 patients, multiple sites across the United States and Europe. It has a core adjudicated lab. It had a data safety monitoring board, The primary safety endpoint was major adverse events at 30 days as defined by death, CDTLR, amputation, DVT, PE, or any major bleeding events. The primary efficacy point was patency at 12 months as determined by duplex studies. The inclusion criteria, this is just a partial list. They looked at Rutherford classification 3 to 5, long segment femoral popliteal disease. A reference diameter of the vessel was between 4.5 and 6.7 millimeters. We wanted to be able to have enough of an entry point at the SFA origin, a patent popliteal artery, because that is usually the distal access point, and at least one patent tibial artery vessel running down to the foot. As I mentioned before, one of the major complications with DETOUR is DVT. So the femoral vein, as identified on mapping, should be at least greater than 10 millimeters in diameter. Basic demographics of the study were multiple comorbidities for a PAD. But things to note is that a good proportion of the patients had very long femoral popliteal lesions, and a significant number of these patients had total occlusions. Up to 96% of the patients enrolled into the study. Procedural characteristics actually for performing this study, things to note is that there was a very high technical and procedural success, 90%, 98% and 100% respectively, and minimal complications intraprocedurally. Clinical outcomes were measured by improvement in Rutherford classification, and things to note is that the improvement was high, it was significant, and it was sustained out to 36 months. The primary patency of the PTAB stent grafts were comparable to surgical historical data. Safety through 3 years for symptomatic DVTs were very low, and freedom from major amputations were very low. So the overall conclusions based on the DETOUR IDE study is that PTAB using the DETOUR system provides a standardized percutaneous technique for long and complex SFA lesions. DETOUR demonstrates durable efficacy through 3 years with primary patency of 58% and freedom from CDTLR of about 67%. The study also reports favorable safety with low DVT rates and low major amputation rates up through 3 years. The DETOUR system was designed specifically for PAD patients that are challenging and advanced, specifically those with long, complex femoral popliteal disease. Now I'll have my, one of the great things about working at Sinai is we have a great collaboration with our vascular surgery team. So I'll have Dr. Rao come up now to finish the evening presentation. Thank you so much.
All right. So I think that was a kind of great overview of the data that we have for the DETOUR device. So I want to focus on kind of some tips and tricks, when I consider using the DETOUR device, PTAB, and then we're going to spend some time really discussing cases because I think that's one of the best ways to kind of learn about the device. So the first thing is, right, you're traditionally taught when you're approaching patients with PAD, it's either conservative, endovascular, or open surgery. And PTAB is kind of a mix of a little bit of both of that. So how do you fit that in your algorithm? Well, for me, in terms of endovascular, some patients where I may choose not to do a traditional endovascular revascularization in the native vessel, and I may choose a PTAB, or number one, if they have some anatomic limitations. So you've all, if you do enough of these cases, you'll see a patient with a really long SFA occlusion, severely calcified. It just almost looks, like it's full of calcium. There's going to be no lumen there. Rather than spending, 4 hours trying to get a wire across, if you get lucky, you do it, and then you try to track a balloon or stent, and you can't really do that well. That's a patient, that typically you just only have an open bypass option, but now PTAB is a good option for that patient. Of course, a patient that has a occluded popliteal aneurysm, femoral aneurysm, there's going to be thrombus there. You probably don't want to recanalize them, so that's another choice, to consider a PTAB. There are patients you're going to not be able to cross even with the best of hands. So if you can't do that, that's where PTAB can also be a good use, good option in these patients. And then finally, you're going to have patients that maybe you've done a SFA intervention. Maybe the SFA intervention was done somewhere else and they undersized the stent, and it's, even if you open that vessel within a year or two, if not sooner, you're going to be back. That's another patient where you may consider going straight to PTAB. And then I think, we had a good talk on this, a good debate about PTAB versus surgical PTFE bypass. I think if you have vein and you believe in the best CLI data, which is a randomized trial, then, still a vein bypass is kind of the gold standard these days. But a lot of patients just don't have vein. And then you have to talk about PTFE bypass versus a DETOUR device. Now, I'm a vascular surgeon, and I love open surgery, but there are some patients I don't want to operate on. So there's patients that would be high risk for surgical bypass. So number one, of course, those with poor cardiopulmonary status. Maybe they have bad CHF, COPD, someone that I don't want to put under general anesthesia. That may be a patient I'm going to opt for a PTAB. There's also patients that just have bad body habits, so morbidly obese. I know if I make an incision in that groin, there's a good chance it's going to break down. It might get infected. Now I have graft in there, and it's going to turn into a mess. Maybe it's a patient that had a prior surgery, a femoral endarterectomy, a prior bypass. Going into reoperative fields, also not an easy thing to do. Additionally, you still have to sew on a vessel, so you may have an open popliteal artery, but if there's a lot of calcium there, a lot of plaque, it's going to be hard to sew to that vessel, and you might not get a good result. You might run into bleeding. So again, another option to use a PTAB. Additionally, I do think there is a decreased length of stay with PTAB because it's a percutaneous procedure versus open surgery, and along with that, I think you have a very low risk of wound healing complications. Again, a minimally invasive percutaneous procedure, so I think that's another added advantage over PTAB. And I think the question becomes, we talked about patients that have failed endo, aren't good at open bypass candidates, and then there's the question of who should just go straight to primary PTAB. So you do an angiogram, you see a SFA occlusion, and rather than trying traditional endo, rather than going straight to bypass, you're like, who should we primarily do PTAB? And I think there's some patients, like we talked about, with severe calcium in their SFA, where you're going to struggle with an endo option where PTAB can come into play. Another thing that comes up is, especially some of my partners that have been in practice a while, they're kind of, they have a way of doing things, it's worked for them, and so this is a new device, a new algorithm. But one of the things that they ask is, what about the risk of DVT, right? You're putting in stents in the femoral vein, which is really a novel concept. So if you look at the data, which is really how we should be driving our decisions, the rate of DVT in the trial was very low. It was under 5%. And actually, that's quite comparable to surgical bypass, which also has a similar rate of DVT. So really, even though I think in theory there's a concern, so far the data has shown us otherwise. Now that being said, PTAB is a great device, but it does have its limitations, and it's not for every patient. So you want to stay on IFU. I think I might have a slide on this. Yep. So number one is vein size. So you want to make sure the femoral popliteal vein is at least 10 millimeters, right? You're putting in around a 6 millimeter stent, so you don't want to be occlusive. Otherwise, you 100% will get a DVT. So make sure the vein is over 10 millimeters, or there has to be a duplicate vein. The other thing that they found more recently with the DETOUR in terms of outcomes and occlusion is the size of the common femoral. So that was actually a big predictor of thrombosis. So if your distal common femoral artery was under 7 millimeters, that predicted earlier failure, poorer patency. And the reason, again, is because it's all same as a surgical bypass. When we talk about surgical bypasses, we think about inflow, outflow, and conduit. So here the conduit's set. The inflow is one, so if you have a small vessel going into your PTAB, that could affect your flow. You're going to get a slower rate in your PTAB, and you might have a higher rate of occlusion. And same thing with the outflow, which we'll talk about, but you need to have at least one vessel down to the foot, like Dr. Song mentioned. But ideally, if you have 2 or 3 vessels, I think those patients are probably going to do better. And then you want to have a landing zone. So these are, unfortunately, if you have a patient where it's the very distal popliteal artery that comes back, there's maybe half a centimeter there before it trifurcates, you're not going to have enough of a landing zone to really do a detour. So in that case, you should consider other routes. So there's a learning curve to the device, and so hopefully by me going over some of these things, you can avoid some of the suffering that I had to. But number one is the access, right? So it's an 8 French device. So PAD patients, sometimes you might not be able to put in an 8 French sheath, or you're worried about putting a perclose at the end. Maybe especially if you're starting out, not the best case, because you do need good femoral access and iliacs to put your 8 French sheath up and over. That being said, I have done one antegrade where I had a little bit of running room in the proximal SFA, but that's a much higher risk access site. So in general, you want to make sure your access is good. The other caveat, kind of trick, is the PT vein access. So this might not sound too difficult, especially if you're practicing and maybe you do RFAs, vein procedures, and you're used to accessing a 2 to 3 millimeter vein. But it can be challenging. This vessel is prone to spasm. There are very talented physicians that have struggled with this. I think some things you can do to help are putting up a tourniquet. So before you get access, really make sure your tourniquet's inflated and the veins engorged as much as it can be. As soon as you get access with your needle, I switch to a micropuncture sheath and I inject some nitroglycerin because, again, to avoid the spasm in the vein. And the other kind of trick I learned is so my access in the PT vein is by the ankle. But even once you put your short sheath in, sometimes you can spasm it with putting your snare up when you're doing the device. So I actually like to put in a long 6 French sheath and get that all the way into the popliteal vein. And that way I don't have to worry about manipulating that PT vein anymore, because once the sheath is in, it's kind of, the PT vein is protected. So I think getting a long sheath into the popliteal vein helps a lot. So I want to spend really the remaining time, we're going to go over 2 cases, and then we'll have a Q&A to answer any questions. But I think the best way to kind of understand how to use the device and what are some good times to use it is through cases. So this is the first case. This is a patient I did, I think last year, but a 66-year-old male, hypertension, diabetes, CHF. He presented with a right foot non-healing ulcer. So this guy had really bad disease. He had a lot of calcium in his vessels, which I'll show you, but he had multi-level disease. He actually had an iliac stenosis, which I did an iliac stent. He had common femoral disease. He had a right SFA occlusion, and then he had a popliteal artery that reconstituted with, I think, 2 or 3 vessels down to the foot. So this is just to show you what I'm talking about. This is his common femoral. You can see chunks of calcium here, and then a chunk of calcium right at the bifurcation. So, we also had a talk on when to treat endo versus open, but one of the things we discussed was if you're at the profunda, at that bifurcation, really endo is high risk, and probably open surgery is a better option there. And then here you can see his SFA, and you can actually see it because it's full of calcium, so you can see this kind of tube of calcium here. So it'd be a very hard, challenging endo case. And then here you can see his SFA above knee popliteal comes back, but still a little bit diseased. And then distally, actually, it gets a lot better. So a decent popliteal, and then at least 3 vessel runoff proximally. So let me stop there, and then maybe I can turn it over to Dr. Song a little bit. So how would you approach this patient? I think there's, number one, we're talking about a common femoral artery stenosis, severe stenosis, near occlusion, and then a SFA occlusion. So what would be your algorithm here?
So, I think this is a great case. And I think, one of the contraindications, I think you also mentioned iliac disease.
Yeah.
So one of the contraindications for PTAB is occlusive aortic iliac.
Do you want to use the mic, just in case?
One of the contraindications for PTAB is occlusive aortic iliac disease. So just based on our traditional teaching, we understand, for any patency of grafts or stents, we have to have good inflow, we have to have good outflow. So by treating the iliac disease first endovascularly and also doing the arterectomy, make sure inflow is good, and making sure the distal, anastomosis site, essentially re-entry site, is good with good outflow was the right choice. I think this is a great case that illustrates that In certain patients, primary PTAB would be a great solution. I'm sure you had a great procedural option, a procedural result, and also a very patent option as well. So very good job.
Well, thank you for the vote of confidence, but I still have yet to show the outcome. But so I think in terms of the options, right? Number one, you want to think about what you're treating. So this patient has a foot ulcer, right? So you want to get inline flow to the foot. That's the teaching. If a patient was a claudicant, you could actually make the argument to probably just endarterectomize, fix the common femoral, and see how he does. Maybe that's enough to get him out of his lifestyle limiting claudication. But number one, he has a wound, so you really want to treat everything. Number two, you want to talk about how you're going to treat it. So before PTAB, probably my option here would be doing a common femoral endarterectomy and then coming back and trying to open up that SFA. But again, I don't know if I'm going to be able to open up that SFA. It's severely calcified, and I just don't know if I can get a wire to cross it. The other option is potentially to do common femoral endarterectomy and then do a fem-pop bypass. But his vessels are super calcified, so sewing to this popliteal artery is not going to be easy. And I'm also going to have to go to his below-knee popliteal artery because there's really nowhere for me to sew easily here. It really comes back by the knee. So, bypass is not a great option for him. So in this case, I opted to do almost a hybrid approach. So I did do a common femoral endarterectomy. And so I brought him back. He had CLI, so I didn't want to wait too long, so I think I brought him back a week or two later. But here you can see the common femoral looks a lot better. This is a pretty robust profunda, and you can even still see the staples are in there. Now, the other thing to note is you need at least 2 to 3 centimeters proximally for a landing zone. So right here you can see there's not really a good SFA origin, but you can actually create that. So that's what I did in this case. So first step is creating that proximal anastomosis like we talked about. So in this case, I got a wire into the SFA, and you can see I'm actually subintimal, which doesn't matter. Actually, I think it's almost easier because you don't have to poke through all that calcium, so sometimes that can actually be advantageous. And then you have to pre-dilate that track. So once I got a wire down, I used maybe a 5 millimeter, 6 millimeter balloon to really create a channel, so that way the device can track. So that's step one. And actually, you can see the other thing I did with endarterectomy is actually did core out the SFA, so that way it gave me a little running room. The next step is you get PT vein access, so we talked about that. I like to put the long sheath in, and then through that I put my snare up. So here you can see my snare is in where I want to cross, and then I have a wire from the SFA, again subintimal, but it doesn't matter. Usually the proximal anastomosis is the easier, in fact almost always it's the easier of the two. When you do this procedure, if you haven't done it yet, they give you a little diagram so you can kind of see the orientation of how you want to put the crossing device. But their needle it's like, if you've used an Outback, it's like an Outback on steroids. It's like a huge needle. We've used it to poke through calcium, poke through stents. It does a really good job of doing that. And in this case, especially with that severe calcium, I think I got it on the first or second try. So anyway, once you do that, you snare a wire. You have a wire now from your arterial sheath on the contralateral side, and then you pulled it out through your venous sheath at the PT vein. So you have a through and through wire, which is very important because it can be challenging to track the device, balloon, stents through the anastomoses that you create. So the first thing you need to do is balloon that anastomosis. So here you can see I'm using I think I used a Serenity balloon, but you want to use something that tracks well, because if you can't use an 035 balloon, you want to use like an 014 if you're using an 014 platform, because otherwise it's going to catch that edge. And sometimes you need a high pressure balloon too. But here you can see a waist here, which I usually have to go to like at least 10, 12, 14 atmospheres to really break it. But that's step one. After you create that, then you want to bring your crossing device, and this is what it looks like. This is the same crossing device you use proximal and distal. So here you can see kind of the orientation, and again, you'll get like a diagram to show you how you want to orient it. But basically, the key to the distal anastomosis, I think, is a couple things. Number one, you want to have good tension on that through and through wire. That's really going to push the device towards the vessel wall through close to the vein, so you can poke through it. And then you want to make sure you have in the right orientation. So you want to take a lot of pictures from above, really know where that popliteal, SFA, wherever is, so you can aim the needle right at it. So that's what we did here. And here you can see kind of how it looks. So you can see how large that needle is. So that's going to poke through a lot, basically most of what you need. And then if you're in the right plane, your wire should just sail down. I like to just fly a Grand Slam wire down once I cross. And then after you do that, you pre-dilate the distal anastomosis just like the proximal. And then you just reline your stents. So you want to start distal to proximal. So here you can see my stent starting behind the knee. You want to at least, again, 3 centimeters of healthy landing zone. And then you want to work all the way back up. Now, the other important caveat of this is your proximal part. So in terms of durability, you want to make sure that proximal stent is basically close to the origin of your SFA, or basically at the origin of the SFA, because one area of restenosis, right, is if it's not covered at the proximal SFA. So you want to make sure your stent goes all the way up. In this case, it's a little weird because I did an endarterectomy, so it's kind of a huge common femoral with the patch. But, I'm well into the common femoral here. And then you can see, just like doing a PTFE bypass, you always get this nice angiogram at the end, like a fully expanded stent. You want to post-dilate the stent. That's also important. And the other nice thing about this is if I was going to do a bypass, a surgical bypass, I still have that option, so I didn't burn that bridge because I wasn't going to be able to do a above-knee pop bypass anyway because if you remember, it was severely diseased and calcified. So my stents end here, so I can still do a below-knee pop bypass down the road if I ever need to. And then good runoff all the way down. Would you do anything differently?
No, I think, like I said, the hybrid approach is very appropriate in this situation. You want to make sure inflow is good, outflow is good. You're not burning any bridges for bypass down the line. I think it was an excellent demonstration. Primary PTAB in a well-selected patient.
Okay. So I have one other case here. So this is another kind of different example of when you may want to consider a PTAB. So this was a 75-year-old male, hypertension, hyperlipidemia, diabetes. He underwent multiple prior failed interventions. So I think they had at least 2 SFA pop interventions. And so at this point, multiple failed endo interventions, you have to kind of think of something else, right? If there's no reason that you can identify of why this, your intervention keeps going down, you don't want to do the same thing. So this typically, if I had a patient like this before PTAB, I'd be talking about surgical bypass. But now PTAB adds another option. Dr. Song, what other options do you kind of have for this, or how else would you manage this? Would you, I think it depends also on what the intervention was. So I believe it was atherectomy, DCB, and spot stenting. So the other options are potentially relining it with a Viabon, which I think is maybe a good discussion to have. So one of the other questions that comes up is why not just reline the SFA pop with the Viabon, and how's that different from doing a PTAB? Do you have any thoughts on kind of how you decide?
So in cases like these, I like to look at the patient and also lesion characteristics. Clinically, if this patient is elderly, has had multiple interventions, multiple comorbidities, I think relining the spot stenting areas may not be the best viable option for long-term patency. So this is where it becomes important to have a very detailed and, informative discussion with their patient and also your vascular surgeon to really understand what options are fully available in order to revascularize this symptomatic patient. And what the mentioned PTAB, availability of PTAB, I think with this patient kind of fits into that classic algorithm for us particularly, multiple interventions, 75 years old, multiple comorbidities would be an optimal candidate depending on his anatomy to make sure that he would be successful for PTAB. So this would be a patient we would definitely offer PTAB as a viable option for revascularization.
Yeah. I think in terms of that question, so Viabon versus PTAB, I think it's a good question. I think the caveat with the Viabon is you're putting it into the native vessels. So In this patient, the reason I didn't do it was they've had multiple interventions, they have calcified disease, and they had prior stents. So I'm putting in basically a second stent in a diseased vessel, which is a Viabon, which may not fully expand. So I'd be worried about getting a good result with that. And then the other caveat is, when you put in a Viaband, sometimes when it shuts down, it can occlude the vessel, and it can cut, you can get clot formation in there, which can embolize. So the last thing you want to do is get a suboptimal result with a covered stent. So that's why I elected for a PTAB in this case. And then the other important question is whether the patient has vein. In this case, the patient had a small vein, so really not a good candidate for a vein bypass. So here you can see it's really not too bad, approximately some disease in the SFA, but the mid-distal SFA is completely occluded, and the popliteal artery comes back behind the knee. Now, the other nice thing about this case is I'm not burning bridges, because in theory I could end my PTAB behind the knee, and so I could still do a below-knee bypass down the road if I wanted to. So in this case, did the same steps that I talked to you about before. Again, you want to make sure your covered stent is past the origin or at the origin of your SFA. If it's a huge profunda, sometimes I'll maybe encroach by 1 millimeter or so, but obviously you never want to compromise your profunda. But if you miss this will be an early cause of failure. So did the PTAB. Here you can see proximally looks good, and then really with just like a surgical bypass, it's really the endpoints you want to look at. So we talked about the proximal, and then you want to make sure your distal endpoint is also healthy, that there's no residual stenosis, dissection, things like that, because that's going to be another mode of early failure. Oftentimes I like to use IVUS down here just to make sure I'm not missing any residual stenosis or dissection, things like that. Because just like a surgical bypass, that if the outflow is compromised, then the whole thing's going to thrombose off. But in this case, the patient did really well. So postoperatively, there's different kind of algorithms for how you want to manage these patients in terms of antiplatelets, anticoagulation. My algorithm has been, if the flow is good through the DETOUR bypass and there's good runoff, 2-3 vessel runoff, I'll just do dual antiplatelet therapy. I think in the trial that was done quite frequently. If the outflow is compromised or the flow is really slow, well, number one, you should consider whether you should even be doing a DETOUR, but if the flow is slow, I'll probably put them on anticoagulation, because if they do thrombose, I worry about kind of forming clot and embolizing. So in that case, I'll put them on like Plavix and Eliquis, Plavix, Xarelto. I do keep them, I mitt them, keep them overnight, and usually, they go home the next day. And then surveillance for me is ultrasound at 2 to 4 weeks, and then every 3 to 6 months after that. Do you have any differences in how you manage them post-op?
No, I think our post-op management is pretty much the same.
Okay.
Those are the same exact features we look for to really help decide DAP versus anticoagulation on boards.
Okay. All right. Well, I want to thank Endologics, of course, for sponsoring this event, and it's been Dr. Song and our pleasure to do this for you. Thank you.